I was asked to talk about reducing warm ischemia time during robotic partial nephrectomy. So let's do that. Okay. So, and again, I'm going to go through this and kind of tell you what I do to reduce ischemia time. I just want to make sure that the overwhelming point I'm trying to make here is to go from 8 minutes from 12 minutes, or to go from 12 minutes from 15 minutes or 14 minutes isn't what I'm trying to say. What I'm trying to say is the primary things are negative margins, prevent a complication, i.e. delayed bleeding, urine leak, do the right thing for the patient, and in addition then reduce your ischemia times as best you can. So good outcome plus a low ischemia time, not low ischemia time to cut a corner, all right? So we'll go through some concepts. I'll go through the maneuvers I think that help, and some techniques and tips, focusing on ultrasound, intracorporeal preparations, or what I call fast technique in the early unclamping, which we've talked about a bit, but also is important in this topic. So again, you know, when we talk about ischemia time in robotic partial nephrectomy, we're talking about warm ischemia time. I know that there has been some work out there being done with cold ischemia and icing the kidney for lap and robotic, but in general, our ischemia times are sufficiently low enough that there's negligible benefit to doing that. And so we're talking about removing blood supply at its core temperature and then reintroducing blood at its core temperature. All right, so here are the contemporary concepts, because this has gone back and forth. There was this ischemia time mattered a lot, then it became ischemia time doesn't matter as much as how much kidney you preserve, and now we're kind of back to ischemia time matters again. And so minutes count, right? Long ischemia time, bad. Doesn't matter how healthy the kidney is. Definitely bad for bad kidneys. But short-term and then long-term function is affected by long ischemia time. And we've seen these numbers as low as 20 minutes affecting long-term and short-term and then long-term renal function. Certainly in kidneys that are impaired, this is a bigger issue. So we do want to achieve the shortest time possible for a patient without cutting those corners we talked about. So, you know, this was a paper we wrote a little bit ago, and the reason why I'm showing this is that it basically nicely demonstrates that every minute does count. Yeah, in general, when you go above 25 minutes, you see a long-term detriment to kidney function, but we saw a 15 and a 20-minute cutoff where there was a benefit even in healthy kidneys. So I think the combination of ischemia time and excisional volume loss both contribute to global renal function. The other point I want to make, and why I'm not going to focus on it in this, is we had about 2,000 patients, about 18% of which we had selective clamping, and ultimately what we saw is in a healthy kidney, two-kidney model, that really we didn't see a lot of benefit with selective clamping and global function. So I'm going to focus on total kidney ischemia time, not selective clamping. And I've sort of stopped doing selective clamping for the most part. Outside of the situations Ronnie Abaza was pointing out, multiple tumors, impaired kidney, or if you really just want to do an off clamp because it's easy enough. Otherwise, I used to routinely do selective clamping, but just based on our own data and a lot of others, it's just not beneficial in the end, because what you're trying to do is preserve kidney function, and you're not really achieving that because we achieve such low ischemia times in general, all right? So number one, routine use of intracorporeal ultrasound. You guys are getting hammered that today, I guess. Everyone's saying use it, use it, use it. And the truth is, use it. The more you use it, the better you get at it. And maybe you have. I did not get good radiology ultrasound training. I mean, I learned how to do a transrectal prostate biopsy as a resident pretty well, but even then it was just the bare bones of how to identify a spot and hit it, and not so much the intricacies of ultrasound. So every time you do a case, use the ultrasound and then pick something on that ultrasound and play with it. Learn it, right? Learn the gain, learn the contrast, learn the Doppler function, learn how you can look at perfusion, learn how you can optimize your image. Learn something about it every time you do it, because no one's teaching us that stuff, and no one's going to teach you. But the more you look at it, the better you are at it. And then when you have a hard case, and you wish you knew how to read that thing better, you'll be glad you did, because you'll amazingly know what you're talking about, what you're seeing, and no one else is going to see it. And you're going to see it, and you say, you see that? And everyone's going to say, no, I have no idea what you're saying. But you're right, because you keep seeing it. You know what it looks like. So get good at ultrasound. That is your time. You don't have time pressure. You have the ability. You have control over the ultrasound. Use it. It is really very important to get good at that. Now, how does this decrease ischemia time? Well, a couple ways. And I'll show you how, but really it's particular cases where it will. So number one, and again, we had talked about this today, yes, you get to mark out your cortical margin, which will help so you know where to cut, and you have a line and you're coloring in the line, and that will of course help. But mostly it's this 3D cognitive fusion concept, right? So you do an ultrasound. I'm not going to spend too much time talking about it because Ronnie did such a good job explaining it, but you're creating a rendering in your head. You know, you see it, you're looking at it, you have the ultrasound, and what you're doing in your mind is you're making this cognitive fusion image, and you know kind of how deep you want to go, how not deep you want to go. You're turning the ultrasound. And so you do that until that picture is ingrained in your head. I got it. I know what this thing looks like from 360 degrees. Because ultimately that confidence of knowing where you need to go is what's going to make it efficient, right? So 3D cognitive fusion, people do it for prostate biopsies off MRIs. It works for that, for certain, many lesions. I'm not going to argue at that point, but it works. But certainly that is the skill you're using here, right? So ultrasound will do that. And so again, this is a completely endophytic tumor, completely endophytic. And I'm trying to mark it out by just using ultrasound. And again, it's looking at it, marking it, and then getting your cognitive view around it. This is sped up a little bit for time. But look, all the way around, and you kind of see this paleness of the tumor up here, but really it's all inside, right? So you come in, you're turning the tip, you're going around, forward, backward. And the one thing I like to do is I like to use the tip. So you pull back till you don't see it anymore, like that, so you know exactly where it is. Don't let it fool you. Put it on, pull it back. On the side, slide it off. On the back, push it off the back. In the front, pull it down to the tip. So that way you get off the tumor and you know you're in normal kidney. All the way around. Now sometimes you can't get all the way around to the back. That's okay. But if you do a nice smiley face, you'll still get what you need. And then the other most important point, I don't know where in this video I show that or not, but once you've marked your whole tumor, figure out where you're going to start your incision, right? And usually it's the most anterior, closest part to you that's facing you, and figure out your angle. And figure out, so this is where I'm going to start, and this is the angle I'm going to start, and everything else will follow suit for the most part. So spend some time in figuring out what that spot is and where that angle is. So for me, I would start in the front because it's facing me, and I'd use the ultrasound to find my angle and cut in that angle, and then take it from there, and usually it keeps you out of trouble. So spend time doing that. So when we looked at this, and again, this is a multi-institutional data set that Dr. Abaza, Jim Porter's involved with, amongst many others. So we got a lot of patients. Although globally, and again, we're talking about small exophytic tumors versus big endophytic, so globally, we didn't see, just barely saw a difference in ischemia time. When you look at any tumor that had at least a 50% endophytic component, bam, there was a significant difference, and this is from a very experienced group, so clearly ultrasound is making a difference in reducing ischemia time for anything outside of the purely exophytic or chip shot tumors. So use it. It works. Number two is this concept, and again, everyone has their own way of doing things, but I like this concept of the intracorporeal preparation, or what I call the FAST technique, and basically what we're doing is setting everything up so it's all ready to go when we go on clamp. That means the sutures are ready, and they're put into the body with the clips on. The ultrasound's ready to go. The robots, the bulldogs are in. So here's just an example of, this is the left side, so all the stitches ready to go. And usually what I do is, I'll do one inner layer stitch first, because ultimately if I need more inner layers, I know that as I'm doing this one, so I don't waste any time. If someone has to bring me in the next one, I ask for it ahead of time. So there's no time wasted for the second or third one. But I'll do one 3.0 V-lock, RB1 needle. It's got a Lapratai on the end, so I can just take a capsule bite and not have to take time with the loop, but not mandatory. And these are CT1 0 vicryls with Hemalock and Lapratai on the ends already. And again, if I need a fourth one, and you could put 4 or 5 in, I just feel like 4 is a good number to prevent tangling and the other stuff that, anything more becomes too much. But if I know I need a fourth one, I know that after I'm putting my second one in, so I ask for it and it's ready to go. I don't waste any time. But it prevents the in and out. The other thing that helps, there are 2 other maneuvers with this. Number one, you need the needle driver and your instruments to do it, so you can check your expired status, you can check your port, everything's working, because you got to switch out your scissor for the needle driver to put these in. So it's our way to check all that's ready to go. And then number 2, the clips fall off, clips don't get on, they get tangled in the port. So all that's already in, so you don't have to worry about that stuff when you're actually, doing this. Putting all the bulldogs in, and I always just put in more than I need. So if I think I need 2, I'll ask for 3. If I need 3, I'll ask for 4. Rarely do I just ask for 1. I just put them there. I just lay them all there. They're hanging out. They all have a little tag on them. I know we talked about that earlier, but somehow they find ways to find hiding places in the abdomen, and you got to find them. But I put them in there, and so if I need them, I can pop them on and off, and it's no problem. I don't have to wait for someone to bring it in. And the worst thing that happens with a bulldog is if you bring it in, and it snaps off the instrument, that thing will go somewhere you never expect it to go. The bulldogs amazingly will go somewhere you can't even imagine how it got there. So having them there ready to go is good, because the 1 in 20 times that happens, it's bad. So just, quick video, putting it up on the diaphragm. Make sure you get good engagement of the diaphragm, because you don't want them to fall out. And then I tuck all the tails over the top of the spleen or the liver, whatever side we're on, because you don't want to cut the stitches by accident. You don't want them to be in the field. So line them all up, put them up over the liver or the spleen, get them out of your way. I don't do it on the lower side, so there are some times where I do a case and there's just something going on with the liver, it's adhesed or something up there, then fine, I won't do it at all. But putting it on the lower end where your fourth arm's coming from, and then it gets all tangled. Bulldogs are ready to go. I can put on 3, I can put on 4. Think about the vein, not think about the vein. Do whatever you want. There's really very little time issues with the Scanlon Bulldogs this way. And then cut it out. So really the only instrument change that's happened is the needle driver to the scissor, right? That's it. Everything else has already been in there. So I just need the sucker and 1 instrument change, and now I just need 1 instrument change back to the needle driver. So that's all I've relied on my assistant to do, aside from the sucker, of course, which is very important. And then I'm running this like I'm mowing the lawn, just covering the surface area. I'm not trying to bring the base together. I'm not individually suturing each vessel collecting system. I'm running the entire base and then just putting the capsular sutures on. So I haven't individually sutured collecting system or vessels in a very long time, and I haven't had that issue. So if you cover the surface area of your tumor defect, I think you're gonna close collecting system. You're gonna get the polar vessels. You're gonna basically close everything you need, and it's fast. I use the V-lock because you can cinch it down once you've done your capsule sutures. I'll show you that. So you get a nice tight closure. Even after the edges come together, you can pull more of that slack out and tighten down the base. So anyways, when we do this technique, ultimately there was no change in anything except overall time, and warm ischemia time was much better with doing all of these maneuvers, which isn't a big surprise. Number 3, early unclamping. So early unclamping is basically, there's no definition to this. Early unclamping is we'll unclamp before we're completely done. And at what point in time that happens is really up to you, and there's no right time to do that. For me, early unclamping is after the base layer is done. So after I've run 3.0 V-locks to cover the surface area of the base, and that could be 1 stitch, that could be 2 stitches, that could be 3 stitches, whatever it is, I'll do it. I'll early unclamp. Very, very rarely will I get to like 12, 13, 14, 15 minutes in a really big, even a really big defect, and not have the base layer done where I feel like, okay, I got to unclamp anyways and just deal with it. So that doesn't happen that often. I think you get really efficient at just, throwing these down in a straight line, not having to look for different areas, just covering it. So you can do it very quickly. So I haven't had that problem. Certainly if I've done it real fast, sometimes I'll put the capsular stitches in before I unclamp just because. But bottom line is, for me, it's between layer 1 and layer 2. So we're clamped, right? Putting the first V-lock. This is a Stratafix, actually. It just depends on which location I'm at. And so for me, I look at this defect and I say, okay, I want to cover this and I want to cover this. I could do that with one stitch here and one stitch here. I could probably take this one down and run it up. But anyways, parenchyma capsule to capsule, right? I don't leave it on the inside. The capsule is what gives you strength. Just like the second layer, for the first layer, it's just as important. You can put it through, put a hemolock, and really, give it some nice tension to hold it in place. Now we'll unclamp. And I chose this particular video. I probably have a bunch of, bloodier ones. But there's just an example of, okay, unclamped. Everything looks good except there is a bleeder, right? So this is a big fear that people have with early unclamping is, all right, well, I'm going to unclamp, and there's going to be all this bleeding. And you don't want to reclamp. That's bad. But I'll tell you, even in these really big defects, it's all manageable stuff. You find 1 or 2 arterial bleeders. You find 3. Just take the stitch and run it around. So here, because it's the corner, I kind of just oversewed the corner. But it's fine. A little arterial bleeding, if you have it, is okay. And then once you get that one, you see the rest is dry. It's as if you're clamped. The little bleeding that happens from the parenchyma when you do this off clamp is nothing. You'll put the stitch in and you'll get a pumper from that needle site. But if you slide the clip down, it just stops. You don't have to do anything more with that. So even an off clamp, if you've gotten the arterial bleeders, it looks like you're still on clamp. You've really saved yourself all that time with early unclamping. So I think early unclamping for me has kind of changed a lot. It has reduced average ischemia time, and I'll show it to you. Basically, the median's 11 minutes, and this is all comers, all tumors, over a whole bunch of patients. But the other point I want to make is the range is tight. Right, so each step, and I'll go back to what I was saying this morning, do everything the same way, and it will be better for the patient because everyone around you will know what you're doing. The range is tight. Yeah, there are a few that are really, really fast, and there are a few that are kind of long. But look at this. If 11 minutes is the mean, we're not even 50% in either direction. So the range for even the really big tumors is tight. So there's not a lot of variation. So if you apply the principles over and over again, you are going to reproducibly achieve this. And despite big tumors, despite anything, we haven't had to go over 25 minutes. Now again, a lot of that's just early unclamping. Say, okay, we're at 22. Take it off and we'll deal with it. But the more you do that, the more comfortable you are dealing with any bleeding that might happen when you do that. So early unclamping has reduced the ischemia time probably more than anything else. And number 2, to me, that's the maneuver that's prevented delayed pseudoaneurysm, AV fistula formation, because if you see the arterial bleeder, you get it. So one of the biggest mistakes that happens with people who do early unclamping is you'll put the parenchymal sutures in because you feel a little uncomfortable not having that in case you want to cinch it down. But if you cinch those down at all and your defect closes a little bit and you have an arterial bleeder, it's very hard to go after it. So just leave it open. Put your base sutures, be happy with those base sutures, take the clamps off, and go tackle a bleeder or 2 if you have it, or none. And honestly, majority of the time there isn't one. But if there is, then you go get it, and you will not get an aneurysm, a delayed bleed, if you do it that way. Future options, I think there are other ways we'll be able to reduce ischemia time. 3D models, that's something that's out there and we're using. You've seen a little bit of it. There's the physical 3D models that's being looked at. I don't know how vigorously that's being looked at, but it's being looked at. And then the virtual reality models, you saw the CVER model today. There's a multi-center trial underway that I'm participating with Jim as well to kind of look at, the value of things like reducing ischemia time and that sort of thing. But there is real value there, and you saw what it was. For a straightforward tumor, for complex tumors, there's probably a lot of value. There's probably going to be some medical things we can do. There's a big paper I was alluding to earlier that came out in JAMA recently looking at the type of fluid to help in kidney injury patients. We're going to look at this in surgically kidney injured patients. Mannitol, I think, is all but pretty much died. It's kind of gone away. Big randomized study showed it doesn't make a difference. I don't think most people give it. We're doing a randomized trial now looking at amniotic membranes and those types of things to look at kidney regeneration post-partial nephrectomy. Maybe there's going to be value there. Perhaps some of you have seen these parenchymal clamps that have kind of floated around. Unfortunately, I don't know of a lot of studies looking at how well that's going to make a difference or not. I don't think that's really matured very far yet, but there's a lot of people trying to figure out a mechanical clamp, parenchymal clamp. And then there's also some interest in laser energies, so to do more off-clamp using argon, holmium, and then even KTP, and they've got some laparoscopic and robotic interfaces to do that. But again, that's very, very early on. So we'll see. We'll see if any of that actually has any future with this. So with that, hopefully we'll not too far behind now, Ronnie, right?
No, we're actually doing pretty good. I think we'll, because we've been asking questions a lot of the time, we've had 10 minutes for that. So I think we'll be able to reduce that.
Okay, good, yeah, so, well, I still feel like I caught us up a little bit, so I feel good about it. Don't take it away from me.
No, we're
Questions? Good. Jim is given the next, he may not be here. Is he here? Yeah.
We're going to have to wear parts of the station to the renal artery stent.
Yeah. Yeah. So, yeah, yeah, it definitely possible. I mean, the whole question is if he's stented because his whole body requires stenting, maybe a partial is not something that he needs at all. But, there are reasons why you stent because of congenital stenosis, and you need really good imaging to know where to clamp, because ultimately, if and this has happened to me, and I do everything I can to avoid it, but if you clamp where the stent is, you're not going to get ischemia, and you're going to bleed all over the place. So you got to know where to clamp.